Okay, well, welcome to the third, actually, lecture in our CME webinar series that we're doing this year. I know that we have some more attendees that are logging in currently, but we'll go ahead and get started. So my name is Avash Kalra. I'm a assistant professor of medicine and transplant hepatologist at the University of Colorado and the director of our liver transplant outreach program as well. And today's topic is going to be viral hepatitis in the outpatient setting. Before we get started, just some housekeeping items. Christy Click has put some information in the chat box. Notably, you'll see information there that she'll put regarding claiming CME for this talk, for attending this talk, as well as options for viewing the video at a later date, as the information will be posted online on the website for this series. In addition, if you have any questions, you can certainly put those into the chat box, and I will address those at the end of the talk. So without further ado, we'll go ahead and get started. First of all, disclosures. I certainly have no financial relationships to disclose, nor to any of the planners or individuals in control of the content for this educational activity today. The next couple of slides basically go over the enduring materials and maintenance of certification credits. These slides can be viewed at a later time, and like I said, all this information will be given in the chat box today, as well as put on the website. And that's both for the ABIM as well as nursing. So today's learning objectives, again, we're going to be talking about viral hepatitis in the outpatient setting. And thank you for joining us today. And I know that there are a few dozen additional attendees that are going to be watching this at a later time. So number one, recognize the global burden of disease related to viral hepatitis and understand strategies for mitigation, including vaccination. Number two, develop a practical approach to managing hepatitis C in the outpatient setting. Three, develop a practical approach to managing hepatitis B in the outpatient setting. And four, understand which patients benefit from screening for hepatitis B and C. So we've got about an hour, including questions, to go. So you have your coffee, now's the time. Okay, and for this presentation, I'll start also by just mentioning that the term viral hepatitis certainly is a broad one, and we'll focus on 4 viruses today: hepatitis A, B, C, and E. Other forms of viral hepatitis certainly include hepatitis related to hepatitis D, CMV, EBV, HSV, adenovirus, and other viruses as well. However, all of these other topics are outside the scope of the 1-hour talk today, and so we'll focus on, like I said, hepatitis A, B, C, and E. I'd also like to give this talk just in the context of the global burden of disease. July 28th, which is just over 2 weeks from now, is the World Health Organization's World Hepatitis Day, which is designed to bring awareness and education to this topic. So it's somewhat timely that we're doing this webinar today. And the World Health Organization calls for essentially a simplified service delivery of viral hepatitis services, bringing care closer to communities. And I'll spend the majority of the time talking about hepatitis B and C with that context. But I'll start with hepatitis A and E to start. So hepatitis A, first of all, as a brief overview, is a virus that's primarily transmitted fecally orally after close contact with an infected person. So spread when an uninfected and unvaccinated person ingests food or water that is contaminated with the feces of an infected person. This disease is closely associated with unsafe water or food, inadequate sanitation, and poor personal hygiene. It's actually the most common cause of viral hepatitis worldwide, typically causing acute and self-limited symptoms, although rarely liver failure and death can occur. So unlike hepatitis B and C, which we'll spend the majority of the time talking about today, hepatitis A does not cause chronic liver disease, but it can cause debilitating symptoms and rarely fulminant hepatitis or acute liver failure, which is often fatal. The World Health Organization notes that in 2016, over 7,000 people died from hepatitis A worldwide, which is about 0.5% of the mortality due to viral hepatitis as a whole. Hepatitis A occurs sporadically and in epidemics worldwide and has a tendency for cyclic recurrences. Every now and then in the news, you might hear about a hepatitis A outbreak. There were actually several in the state of California a few years ago. And epidemics related to contaminated food or water can erupt somewhat explosively. There was an epidemic in Shanghai in 1988 that affected about 300,000 people, for example. In the United States, in 2018, a total of 12,474 cases of hepatitis A were reported. But certainly there was some underreporting likely as well. And so the actual number of cases was likely almost 25,000. The incidence overall decreased more than 95% from 1995 to 2011. But since especially 2016, large person-to-person outbreaks began occurring. The majority of these reports were related to multiple outbreaks of infections among persons reporting drug use or homelessness. So the presentation for hepatitis A, first of all, the virus has an incubation period of 2 to 4 weeks, during which time patients can be infectious and transmit the virus to others, which contributes to the large outbreaks that can occur. Symptoms are somewhat nonspecific, but include fever, diarrhea, nausea, and jaundice. In terms of diagnosis, so acute hepatitis A is diagnosed by serologic testing to detect hepatitis A specific immune globulin, IgM, antibodies in the blood. Now, there are additional testing that can include reverse transcriptase polymerase chain reaction, so PCR, to detect the viral RNA. Treatment is supportive. So there's no medication that treats hepatitis A. Rarely, in the setting of acute liver failure from hepatitis A, liver transplantation is required. There is an immune globulin that I'll mention that can provide short-term protection against hepatitis A, both pre and post-exposure. Immune globulin must be administered within 2 weeks after exposure for maximum protection. Prevention simply boils down to vaccination and also hygiene and sanitation. So I'll talk more about vaccination on the next slide, but just a reminder that given that the virus is transmitted through the fecal-oral route, good hand hygiene, including hand washing after using the bathroom, changing diapers, and before preparing or eating food, especially in areas where there's been a hepatitis A outbreak, is integral to hepatitis A prevention. In terms of vaccination, there's multiple options for vaccination for hepatitis A. So there's a 2-dose hepatitis A series. I've listed the options there on the slide, as well as a 3-dose series over the course of 6 months for a combined vaccine for hepatitis A and B. Transitioning quickly over to hepatitis E now, because like hepatitis A, this is also transmitted via the fecal-oral route, transmitted mainly through contaminated drinking water. And this infection is also usually self-limiting and resolves within a few weeks. There are 4 different genotypes for hepatitis E. So genotypes 1 and 2 have been found only in humans. Genotypes 3 and 4, on the other hand, circulate in several animals, including pigs, wild boars, and deer, without causing any disease. However, they can occasionally infect humans. The diagnosis for hepatitis E is made with an anti-hepatitis E IgM, as well as there's an available test for hepatitis E RNA PCR. Now, a few caveats regarding hepatitis E. Rarely, hepatitis E acutely can be severe and result in acute liver failure. Pregnant women with hepatitis E, particularly those in the 2nd or 3rd trimester, are actually at increased risk for acute liver failure, as well as complications such as fetal loss and mortality. This has to do with a lot of causes, including the types of genotype that pregnant women tend to experience when they are exposed to hepatitis C, as well as immunologic changes of pregnancy, decreased natural killer cell activity that is often required to combat this virus. Up to 20 to 25% of pregnant women can die if they get hepatitis E in the 3rd trimester. Cases of chronic hepatitis E, again, chronic hepatitis E, have been reported in immune-suppressed people, particularly organ transplant recipients on immunosuppressive drugs, including with genotype 3 or 4. This is pretty uncommon, but is always on the differential for chronic liver disease in the immune-suppressed population. So to just summarize what we've talked about so far, we've talked about hepatitis A and E briefly. These are, again, in the outpatient setting, occasional presentations that you might see regarding viruses transmitted through the fecal oral routes. And again, the treatment in the vast majority of these cases is supportive. Now, the rest of the talk is going to focus on hepatitis B and C, and I'm going to talk about hepatitis C first, not going in alphabetical order. And again, we're going to talk about this in the context of the global burden of disease. So the World Health Organization estimates in 2019 that 58 million people worldwide were living with hepatitis C. Also during that year, 1.5 million people were newly infected with chronic hepatitis C. Hepatitis C, just like hepatitis B, can lead to lifelong infection. And the World Health Organization estimates that 1.1 million deaths occurred in 2019 due to these infections, hepatitis B and C combined, and their effects, including liver cancer, cirrhosis, and other conditions caused by viral hepatitis. And you can somewhat appreciate this on this map here. The highest burden of disease is in the Eastern Mediterranean region and European region, with 12 million people chronically infected in each of those regions, as well as the Southeast Asia, Western Pacific, and African region. Less so in the United States, but growing over time certainly as well, which we'll talk more about shortly. In terms of the natural history of hepatitis C, so this gives a rough diagram in terms of the progression of liver disease with hepatitis C. There is a percentage of patients that clear hepatitis C on their own. And so as a result, only up to 85% of patients actually develop chronic hepatitis. I'll talk more about how we can differentiate that with blood tests in a moment. 20 to 30% of the patients with chronic hepatitis develop cirrhosis. And certainly once the development of cirrhosis has occurred, there's a risk of decompensated cirrhosis, risk of developing that of 2 to 5% per year, as well as a risk of hepatocellular carcinoma, a risk of 1 to 4% per year. Just a reminder that just 2 years ago, the Nobel Prize in Physiology and Medicine was given to this trio who were reunited and talked about their achievement during that year's AASLD liver meeting conference. This was a screenshot that I took actually during the meeting, and I've circled the 3 Nobel Prize winners. These were the individuals who discovered the hepatitis C virus in the 1980s. Prior to that, it had been realized that there was an unknown virus causing chronic hepatitis. Dr. Alter was the individual who did some methodical studies of transfusion-associated hepatitis to discover that. Michael Houghton then used an untested strategy to isolate the genome of the new virus, and he named it hepatitis C, logically, as hepatitis A and B existed at that point. And then Dr. Rice provided the final evidence that showed that the hepatitis C virus alone could cause hepatitis. That discovery certainly has led to game changers in medicine, including treatment, which we'll talk about momentarily. Prior to their discovery, meaning prior to the ability to test, for example, blood that was transfused, the risk of hepatitis C from a blood transfusion was 1 in every 14 units. Now it's 1 in every million, which is really remarkable. It's a story of progress in medicine, certainly, and hepatitis C can be cured at this point. Oral antiviral therapy for 8 to 12 weeks can cure most people who are infected with hepatitis C. And this is something that we commonly deal with in the outpatient setting, and we'll talk about a practical approach to this shortly. In 2019, in the US, worldwide, 9.4 million people were receiving treatment for chronic hepatitis C, and that's greater than a 9-fold increase since 2015, and it's only grown since then. So who is at risk for hepatitis C? Well, people with HIV infection are at risk, as well as current or former people who use injection drugs, including those who injected only once many years ago. I'll mention too that intranasal cocaine use is also a risk factor for development of hepatitis C due to microvascular bleeding that can occur when doing that, and can lead to transmission of the virus through the bloodstream. People with selected medical conditions including those who ever received maintenance hemodialysis, prior recipients of transfusions or organ transplants, including people who received clotting factor concentrates before 1987 and a transfusion of blood or blood products before July of 1992. Again, that was the time period at which blood that was being transfused could be tested for hepatitis C. Certainly, needle sticks and mucosal exposures to hepatitis C positive blood can lead to an infection with hepatitis C, and children born to mothers with hepatitis C infection as well are at risk. So what are the recommendations now in the outpatient setting for hepatitis C testing? Well, it's pretty simple. At this point, one-time routine opt-out hepatitis C testing is recommended for all individuals aged 18 or older, as well as individuals less than 18 who have activities or exposures, other circumstances, such as, for example, IV drug use or being born to a mother with hepatitis C, placing them at an increased risk of hepatitis C infection. Prenatal hepatitis C testing is part of routine prenatal care with each pregnancy, as well as periodic repeat hepatitis C testing that should be offered to anyone with activities, exposures, conditions, or circumstances associated with an increased risk of hepatitis C exposure. So in terms of the kinetics of hepatitis C, so as I mentioned earlier, 15 to 25% of people appear to resolve their infection without any obvious clinical sequelae. So patients who clear their hepatitis C typically do so within the first year of exposure. Again, that's only about 15 to 20% of patients at most. But in those patients, there is not thought to be an increased risk of long-term liver injury, such as chronic hepatitis or cirrhosis. Now, chronic hepatitis C infection develops in most people and occurs with persistent or fluctuating ALT elevations, indicating active liver disease in 60 to 70% of chronically infected patients. In the remaining 30 to 40% of chronically infected people, ALT levels are actually normal, and so explains the often seen phenomenon of somebody being diagnosed with hepatitis C but having normal liver enzymes on their blood work. The hepatitis C antibody, so you can see in the yellow line here, develops over the first few months and persists. And this will always stay positive even if the patient has been treated. And a common thing that is seen in the outpatient setting is the initial screening test is the hepatitis C antibody. Now, I already talked about how up to 15% of patients who are exposed to hepatitis C clear the virus on their own. And so a positive hepatitis C antibody does not mean that the patient has chronic hepatitis C. It simply means that they have been exposed to the virus in the past and they may have spontaneously cleared it or even been treated in the past. And so the next test after that to confirm the diagnosis is the hepatitis C RNA level, which persists from the time of infection till treatment or spontaneous clearance. And so I would encourage anybody in the outpatient setting screening for hepatitis C to then obtain a hepatitis C RNA if the hepatitis C antibody is positive. We'll talk about treatment in a moment, but how do we first of all counsel patients in the outpatient setting who are diagnosed with hepatitis C? Well, first of all, to prevent hepatitis C transmission, we recommend avoiding activities that can cause, again, microvascular bleeding that could lead to transmission of the infection, which again is a bloodstream infection. So avoiding sharing toothbrushes and dental or shaving equipment, certainly preventing blood contact with others who have hepatitis C. Stop using illicit drugs, and those who continue to inject drugs should take precautions to avoid viral transmission. The risk of sexual transmission is low, but certainly we recommend practicing safe sex practices always. Additional recommendations would be to avoid alcohol consumption. So excess alcohol may lead to progressive liver disease and often does in these patients. It increases the hepatitis C RNA replication and actually reduces the response to treatment as well. Consider treatment for hepatitis C, so we'll talk about that. Vaccinate for hepatitis A and B. Get tested for HIV given the overlapping risk factors and possibility of co-infection, and encouraging family members to get screened as well. Again, the screening test simply is the hepatitis C antibody to start with, and then if positive, the hepatitis C RNA PCR to follow up. So prior to treatment, it's recommended to evaluate for advanced fibrosis. So we talked earlier about the natural history of hepatitis C and how 20 to 30% of patients with chronic hepatitis C develop cirrhosis. So we evaluate for advanced fibrosis using non-invasive markers and/or elastography, rarely nowadays liver biopsy. And again, this is to facilitate decision-making regarding hepatitis C treatment strategy, but also determine the need for initial additional measures for the management of cirrhosis, such as, for example, hepatocellular carcinoma screening in patients with advanced fibrosis. When I say non-invasive fibrosis testing, a common, and now the most common way to do this is transient elastography or FibroScan, which is the patented technology for vibration-controlled transient elastography. Now, this is a test that can be ordered at many centers without the need to see a hepatologist. This is a test that uses ultrasound technology, and it's measuring a few components. So it's painless and simultaneously measures two quantitative parameters. So liver stiffness, measured in kilopascals, which correlates to liver fibrosis, and controlled attenuation parameter, which is correlated to liver steatosis. And both of these quantitative measurements or parameters are assessed on the same volume of liver tissue, about 3 cubic centimeters. Actually, an area that's about 100 times larger than the area that's evaluated during a standard liver biopsy. So at our center, this FibroScan can be ordered by anybody, again, without the need to see a hepatologist. And so, again, with the focus of this being on the management of viral hepatitis as an outpatient, if somebody is diagnosed, for example, in a primary care clinic with chronic hepatitis C, they can be referred for a FibroScan or transient elastography. A hepatologist, such as myself, will read the report and then send the report back to the referring physician or provider. All patients beginning hepatitis C treatment should also be assessed for hepatitis B. And this is because cases of hepatitis B reactivation, so an increase in the viral load for hepatitis B, during or after direct-acting antiviral therapy for hepatitis C have been reported in co-infected patients who are not already on hepatitis B suppressive therapy. So what's the goal of therapy? Well, the goal of therapy is quite simple. Treating hepatitis C infected patients is to reduce all-cause mortality and liver-related health adverse consequences, including end-stage liver disease, such as decompensated cirrhosis, hepatocellular carcinoma, by the achievement of virologic cure, as evidenced by a sustained virologic response. Sustained virologic response is defined as a negative viral load 12 weeks after completing antiviral therapy, and it is synonymous at this point with a cure for hepatitis C. In terms of when and in whom to initiate treatment, treatment is now recommended. This is based on the most recent hepatitis C guidelines, and which are co-authored by the AASLD, which is the American Association for the Study of Liver Disease, and the Infectious Disease Society of America. Treatment is recommended for all patients with acute or chronic hepatitis C infection, except those with a short life expectancy that cannot be remediated by hepatitis C therapy, liver transplantation, or other directed therapy. So essentially, anybody with chronic hepatitis C is a treatment candidate at this point. Now, many of you may have followed along the interesting history of the evolution of hepatitis C therapy over the last decade or more. Prior to 2011, the only available treatment for hepatitis C was interferon, which was certainly not direct antiviral therapy. And for any of you who used interferon in that era, you'll know that that treatment modality was associated with numerous side effects, complications, intolerance on the part of the patients, as well as a low efficacy rate of less than 50%. Starting in 2011, direct-acting antiviral therapies became available. So I don't have time for the purposes of today's talk to go through the pharmacology of these medications, but suffice to say that all the medication names that you see target different aspects of the hepatitis C virus and its ability to replicate. Initially, through the first few years of this direct-acting antiviral or DAA therapy era, the medications that came out were genotype specific. So there are many genotypes for hepatitis C and then many actually subgenotypes. Starting in about 2016 to 2017, pan-genotypic, meaning medications that are effective at curing all genotypes, became available. And those are commonly the medications that are used at this point. So you can see that the pan-genotypic agents that you're probably going to see the most often. First, the combination of sofosbuvir and velpatasvir, which is Epclusa. The other is glecaprevir and pibrentasvir. No matter how many times we talk about these names are still hard to pronounce, but the brand name for that is Mavyret. This is just an example of one of the what we call next generation direct-acting antivirals, or the pan-genotypic agents. This is showing the combination that is produced as the brand name Mavyret. So in vitro showed additive synergistic antiviral activity, a high barrier to resistance, which was a problem with some of the earlier agents, and potent against some of the common polymorphisms for NS3 and NS5A. These are some of the targets of these medications. These are once daily oral dosing, minimal metabolism and primary biliary excretion, and in the case of this medication, negligible renal excretion as well. At this point, the treatment for hepatitis C for treatment-naive patients, so again, that means patients who have not received prior therapy for hepatitis C and patients without cirrhosis, can be found most easily on a website called hcvguidelines.org, which is, again, maintained by the AASLD and IDSA for up-to-date recommendations for treatment for hepatitis C. And I'll include a screenshot here shortly, but essentially, this is a great resource for anybody managing hepatitis C as an outpatient. It allows you to essentially go through an algorithm for patients to treat them as an outpatient. This is just an example, but treatment-naive patients with cirrhosis, it goes over a pre-treatment assessment. So that includes the fact that a biopsy is not required, that there are testing available to essentially rule out advanced fibrosis, education, pre-treatment lab testing, which includes the quantitative hepatitis C RNA, an HIV test, and a hepatitis B testing as well as a serum pregnancy test in women. And then gives the recommended regimen. So in this case, Epclusa for 12 weeks, Mavyret with 8 weeks, for example. Now, what about patients with decompensated cirrhosis? So first of all, this is a situation where we would recommend referral to a transplant center due to the decompensated cirrhosis and the possible need for a liver transplant. Now, this has changed somewhat over the last few years, but the question often arises, or certainly arose more commonly in the past, of when to treat patients with hepatitis C who had decompensated cirrhosis and required liver transplantation. So the pros to treatment certainly increases the waitlist survival, actually increases the rates of removal from the transplant list, as treating the hepatitis C can improve some of the decompensations that these patients develop. It eliminates the possibility, or actual certainty, in fact, of hepatitis C reinfection in the organ graft and improves survival after liver transplantation. Now, the cons to treatment, the main con to treatment was that in the past, this might delay transplantation because that would mean that the patient can no longer receive a hepatitis C positive graft. Sort of put a line through this because that has sort of changed at this point. At this point in the era of transplant medicine, anybody essentially anybody can receive a hepatitis C positive graft, whether they've been treated for hepatitis C or not in the past. For many years, transplant centers were only transplanting hepatitis C positive donor livers into hepatitis C positive recipients. And so in that setting, it made sense in some cases to not treat the hepatitis C because it would increase the donor pool for that patient. Now, hepatitis C positive grafts are sometimes transplanted into hepatitis C negative recipients, which, before the direct-acting antiviral therapy era would have sounded crazy just because of the lack of therapy. Now, with how efficacious these antiviral therapy medications are, curing hepatitis C over 95% of patients and over 99% of patients in most populations, we have an option for treating these patients after transplant. And again, it does increase the donor pool for all patients at this point. Now, this shows, this is from a study in gastroenterology in 2017, the risk of hepatocellular carcinoma in hepatitis C patients treated with direct-acting antiviral therapy. And the bottom line, which is sort of a bluish color, shows patients who achieve sustained virologic response or cure from their hepatitis C. The y-axis shows the cumulative incidence of HCC. And you can see that compared to the red line, which is the no SVR, there's a significant decrease in the risk of hepatocellular carcinoma, which persists months after ending treatment. This is the website I talked about earlier, so hcvguidelines.org. Which it goes over recommendations for testing, managing, and treating hepatitis C. You can see that there are some drop-down menus there, including initial treatment for hepatitis C infection, including retreatment of people in whom prior therapy has failed. And this is really an area of medicine that can be managed in primary care clinics without seeing a hepatologist, especially if they do not have cirrhosis, and certainly if they don't have decompensated advanced liver disease. Access to hepatitis C treatment, I'll mention, does remain limited in many parts of the world. So of the 58 million people living with hepatitis C infection in 2019, only an estimated 21%, or 15 million out of the 58 million, knew their diagnosis. And of those diagnosed with chronic hepatitis C, only around 60% had been treated with direct-acting antivirals by the end of 2019. And so this is an area worldwide still for improvement to this day. Okay, so we're halfway through, so you can have another sip of coffee, and we'll move on now to transitioning away from hepatitis C to hepatitis B. And those are my daughters walking in a field, I guess, outside. Okay, so hepatitis B, World Health Organization estimates that 296 million people were living with chronic hepatitis B infection in 2019. 1.5 million new infections each year. The burden of hepatitis B infection is highest in the Western Pacific region and the African region, where, and these are staggering numbers, 116 million and 81 million people respectively are chronically infected. Just take a moment to let those numbers process. We've focused a lot on treatment of hepatitis C in hepatology over the last decade. The management of hepatitis B worldwide still has a long way to go, given the staggering numbers of people infected worldwide. In 2019 alone, hepatitis B resulted in an estimated 820,000 deaths, mostly from cirrhosis and hepatocellular carcinoma, which, as we'll talk about in a little bit, can occur in patients with chronic hepatitis B even without cirrhosis. So this is actually a similar map to the map of hepatitis C that I showed earlier. I'll mention here too that this reflects as well just the access to medical care in a lot of parts of the world, and leads to a lack of awareness that people even have hepatitis B. And if they even do, there's a lack of access to long-term management and treatment in the areas where hepatitis B prevalence is high, including parts of Asia and Africa. There's a tremendous medical need, like I said, for screening, vaccination, and linkage to medical care. I mentioned the global burden of disease. In the US alone, 2 million people, 15 million in Europe, 90 million in China, staggering numbers, like I said. Over 2 billion people worldwide are actually anti-hepatitis B core antibody positive, so have been exposed to hepatitis B. Again, just remarkable numbers. So in highly endemic areas, hepatitis B, a bloodstream infection, just like hepatitis C, Most commonly is spread from mother to child at birth, so perinatal transmission, or through horizontal transmission, which is exposure to infected blood, especially from an infected child to an uninfected child during the first 5 years of life. Development of chronic infection is common in infants infected from their mothers or before the age of 5 years. And that's in contrast to people who develop or are infected with hepatitis B as an adult, in which case the body's own immune system typically clears the virus within less than a year, often a few weeks to months. Chronic infection, though, common in patients who are exposed at an early age. Part of the reason for horizontal transmission at an early age, too, is that the hepatitis B virus, unlike any of the other viral hepatitis infections, can survive outside the body for at least 7 days. And during this time, it's still virulent, so it can still cause infection if it enters the body of a person who is not protected by the vaccine. In the United States, the advent of a vaccine, certainly for hepatitis B, which was licensed, again, the years and the x-axis here on this timeline was licensed in the early to mid 80s, resulted in an incidence of infection that declined rapidly. And during the 1980s, the use of hepatitis B initially rose and then, as you can see, decreased. Among injection drug users and also the population of men who have sex with men, the decline in hepatitis B incidence as the 80s and 90s went on was also attributed to behavioral changes in response to the HIV epidemic at the same time. Hepatitis B incidence continued to decline during the first half of the 1990s, at least in part due to the widespread use of the hepatitis B vaccine, which was in response to regulations issued by OSHA, so the Occupational Safety and Health Administration. Future declines in incidence are expected to occur as a result of the implementation of routine infant and routine adolescent vaccination as well, which have been recommended since the 1990s. Now, there has been a slight increase. This graph only goes to 2013, but I'll say that there has been a slight increase in 2016 and 2018, and that's due to increased rates of IV drug use in the US and worldwide as well. In high prevalence areas, the lifetime risk of hepatitis B infection is over 60%. And most infections, again, this is on the right column, sub-Saharan Africa, the Far East, most infections are acquired at birth or during early childhood when the risk of developing chronic infection is the highest. In these areas, because most infections in children are asymptomatic, very little acute disease related to hepatitis B occurs. But rates of chronic liver disease and liver cancer in adults are very high. In low prevalence areas, so such as North America, Western Europe, the lifetime risk of infection is less than 20%. Most hepatitis B infections in these areas occur in adults in relatively well-defined risk groups. Risk of chronic disease is low, as I mentioned, and therefore risk of decompensated cirrhosis and risk of hepatocellular carcinoma are low as well. So hepatitis B is also spread by needle stick injury, tattooing, piercing, and exposure to infected blood and body fluids. Transmission of the virus may also occur through the reuse of contaminated needles and syringes or sharp objects, either in healthcare settings or in the community or among persons who inject drugs. Sexual transmission is more prevalent in unvaccinated persons with multiple sexual partners. And hepatitis B infection acquired in adulthood leads to chronic hepatitis, as I mentioned, less than 5% of the time, whereas infection in infancy and early childhood leads to chronic hepatitis in about 95% of cases. And this is really the basis for strengthening and prioritizing infant and childhood vaccination as we aim to reduce the global burden of this disease. Now, as of 2019, 30 million people, about 10% of all people estimated to be living with hepatitis B were aware of their infection. And so what's a practical approach to testing with the resources that we have, at least, in most of the settings in which we practice? So all patients need this so-called triple panel when evaluating for hepatitis B. And I'll talk about who to screen a little bit later, but a positive hepatitis B surface antigen indicates infection of hepatitis B. All patients should also be tested for hepatitis D if they are hepatitis B surface antigen positive. Again, hepatitis D is a separate topic entirely, but I'll mention simply that hepatitis D requires a positive hepatitis B surface antigen to be present. And so if someone is positive for hepatitis B surface antigen, it is recommended to screen for hepatitis D as well. We check for a hepatitis B anti-core antibody. That's the lowercase c, which indicates exposure and persists. And anti-hepatitis B surface antibody as well, considered immune if the titer is greater than 10 micro international units or milli international units per milliliter. Now, if of these three tests, the only test that's positive is the anti-surface antibody, that means that the patient has been vaccinated previously, or can be positive if in the setting of someone who has been exposed to hepatitis B, but cleared, which would also show an anti-core antibody. So again, if it's only the surface antibody, they're vaccinated. If the surface and core are positive, they've been exposed and cleared the virus. Hepatitis B surface antigen positive indicates infection in all cases. For patients who are surface antigen positive, they also need these additional tests. So a hepatitis B E antigen, an E antibody, DNA PCR to quantify the viral load, an ultrasound to screen for chronic liver disease, as well as complications such as liver cancer, hepatitis C antibody, routine liver tests such as a CMP and CBC, hepatitis A total antibody to ensure that they're vaccinated to hepatitis A, HIV antibody, a FibroScan to screen for fibrosis non-invasively, and like I said, hepatitis D total antibody as well. If that's positive, you would check a hepatitis D RNA PCR as well. And then lastly, evaluating a patient with hepatitis B surface antigen, I want to ask questions that will impact management decisions. So do they have a family history of HCC and cirrhosis? That's going to lead you to screen these patients long-term for HCC. Do they have an alcohol history and current use? Certainly, if so, you'll be counseling them to reduce, ideally eliminate alcohol completely due to the risk of accelerated liver disease over time. What's the renal function? That's going to determine treatment options. Pregnancy status, again, that's listed here, although it's now standard prenatal care, certainly in the United States, to screen all pregnant women for hepatitis B. And then family testing as well for hepatitis B. Liver biopsy is really used in select cases when there is concern for advanced fibrosis, perhaps discrepancy on imaging versus the FibroScan, just as an example. So up to 40% of people with chronic hepatitis B develop significant clinical consequences. That includes cirrhosis, liver failure, or HCC. And 25% of people with chronic hep B will die prematurely from these complications. Shown here is a clear degradation where increasing hepatitis B DNA level corresponded to an increased risk of incidence of HCC. The highest risk of HCC, that's hepatocellular carcinoma, was in those with a hepatitis B DNA level of at least 1 million copies per milliliter. And this observation has stood the test of time as well. Recall that these results were for a study population that was predominantly hepatitis B E antigen negative with ALT levels that were low, less than 45. And so again, a high viral load, essentially indicating worse outcomes such as HCC. This slide contains examples of the progression of fibrosis according to the Medivir staging system, simply showing that over time in patients with chronic hepatitis B, there's a risk of developing advanced fibrosis. So this is simply a straightforward diagram showing what this looks like histologically. Stage 4 is cirrhosis and includes the development not only of bridging fibrosis, but nodules in the liver histologically as well. If patients have stage 1, 2, or 3 fibrosis, theoretically, that fibrosis can regress and reverse all the way to no fibrosis with management of the disease. The Institute of Medicine, all the way back in 2010, released a document going over the barriers to prevention and control of hepatitis B and identified some issues, including simply the lack of knowledge and awareness among, the lack of knowledge and awareness about chronic viral hepatitis among healthcare and social service providers, as well as among at-risk populations and members of the public. There's also an insufficient understanding about the extent and seriousness of the public health problem, which I think hopefully I've driven home with by talking about just how significant this disease is worldwide. What are the outcomes and how can we improve this? Well, certainly wide screening is recommended as part of good primary care. At-risk people and communities actively seeking testing, preventive services, and appropriate medical management. And we know that better information will lead to obviously an improved understanding of both hepatitis B and C, more effective and targeted prevention programs, and more research on effective vaccination and treatment options as well. As noted in the 2008 CDC recommendations for hepatitis B screening, the prompt identification of people infected with hepatitis B will allow for the implementation of important interventions to reduce morbidity and mortality. So clinical evaluations to detect onset and progression of hepatitis B related liver disease, for example, early initiation of antiviral therapy, we know can delay or reverse progression of liver disease. Detection of hepatocellular carcinoma at a potentially treatable stage, and as well as allow us to implement interventions to reduce progression of liver disease. And that includes hepatitis A vaccination and counseling to avoid excess alcohol use. So who should we screen for hepatitis B? We talked about hepatitis C. That's pretty straightforward. You screen any adult over the age of 18 at least one time. In terms of candidates for screening hepatitis B, well, we talked about individuals co-infected with HIV or hepatitis C already. We talked about pregnant women as part of routine prenatal care. In addition to that, guidelines recommend screening for hepatitis B in persons born in high and intermediate endemic areas, US-born children of immigrants from high-risk areas, certainly household and sexual contacts of persons who are hepatitis B surface antigen positive, people who have ever injected IV drugs, who have multiple sexual partners, history of STDs, men who have sex with men, inmates of correctional facilities, and individuals with chronically elevated liver enzymes as well. Now, we talked earlier about how the most common form of transmission worldwide for hepatitis B is mother to child. This essentially just goes over the times during which mother to child transmission might occur. So it can occur at the intrauterine level, which can lead to complications such as laceration of the placenta and threatened preterm labor. It can occur at the perinatal time. Again, this is the majority of patients due to microtransfusion during the delivery, as well as swallowing of infective fluid. And it can occur postpartum as well with exposure to maternal body fluids. And so the major preventive strategy worldwide to lowering the burden of chronic hepatitis B is immunization of newborns. And so hepatitis B vaccination is given right at the time of birth. Really it's within essentially minutes of birth, as well as the administration of hepatitis B immune globulin, which is a form of immunoprophylaxis to patients, to infants born to patients with hepatitis B. And as you can see here, this drastically lowers the risk, the rates of infection in these infants if managed appropriately in the perinatal period. So the key points for hepatitis B so far: test all adults, all immigrants from certain areas, especially Asia and Africa, all patients with unknown hepatitis B vaccine status. Hepatitis B core antibody indicates exposure. There is a reactivation risk, which I'm going to talk more about in a few slides. recommend vaccinating all adults who are negative on that triple panel. So if their surface antigen's negative, their surface antibody is negative, and their core antibody is negative, they don't have hepatitis B, they've never had hepatitis B, but they've also not been vaccinated, and so they should be. And then we screen patients, some certain patients, for HCC who are surface antigen positive, and I'm going to get to that shortly. So what are the preferred therapies for chronic hepatitis B? Well, at this point, the medications that are typically used are entecavir or tenofovir, and there's two forms of tenofovir. For short, TAF or TDF. TAF stands for tenofovir alafenamide. TDF stands for tenofovir disoproxil fumarate. TAF is the sort of more recent medication, brand name is Vemlidy, which has lower rates of bone disease and renal abnormalities. And so in that population, we'll use the tenofovir formulation of TAF. At this point, rarely are we using interferon unless they're co-infected with hepatitis D. Lamivudine, adalfovir, for example, these are medications you might have heard of in the past, should not be used at this point. And again, it's really down to entecavir and tenofovir for the vast majority of patients. Tenofovir is used in patients who have HIV or prior exposure to lamivudine. And currently, TDF is the recommended medication for use of management of chronic hepatitis B in pregnancy, although data more recently shows safety for tenofovir AF as well. So what are we achieving with treatment of chronic hepatitis B? So sustained hepatitis B DNA suppression is associated with lower rates of cirrhosis, reversal of fibrosis, reversal of liver decompensation, reducing risk of HCC, reducing liver-related mortality, and improved survival. The goal of treatment is to prevent hepatitis B complications and to suppress the disease. This is a little bit different, you'll note, from hepatitis C treatment that we talked about earlier, where the goal is simply to cure, to eradicate the virus completely with that sustained virologic response. We're targeting therapy for chronic hepatitis B for those at risk for disease progression. So patients with active chronic hepatitis B and cirrhosis. So we treat now with active chronic hepatitis B, advanced fibrosis, co-infection with HIV, and special populations such as patients on immunomodulatory therapy in pregnancy. Deferring treatment for inactive chronic hepatitis B, so normal liver enzymes, for example, and a low hepatitis B DNA level. Like I said, this is often not a cure. Current therapy is infrequently achieves surface antigen loss. The pooled estimate for surface antigen loss for patients is 1 to 1.5% per year. Actually, it's higher with interferon than nucleoside or nucleotide therapy. The next couple of slides essentially go over algorithms for treating hepatitis B. And for those of you watching or listening, I'd simply encourage you to use the AASLD guidelines for this if you're managing this in your clinics, rather than committing each of these sections of the algorithm to memory. The 2018 is AASLD guidance for hepatitis B is the most up-to-date guidance, and this is essentially taken directly from that paper, showing essentially that we treat patients who are hepatitis E antigen positive, who are non-cirrhotic with a high hepatitis B DNA level of over 20,000 and a ALT that's greater than 2 times the upper limit of normal. And then if the E antigen is negative, it's the same treatment threshold except for the DNA level being over 2,000 instead of 20,000. In terms of monitoring patients not on antiviral therapy, so monitoring patients with chronic hepatitis B not on antiviral therapy, we monitor these essentially with blood work and occasionally imaging as well. I'll leave this here just for your review, but again, this splits it up between patients who have E antigen positive and a high DNA versus E antigen negative and a low hepatitis B DNA. Now, who do we screen for HCC? The AASLD guidelines recommend screening for hepatocellular carcinoma in hepatitis B carriers who are at high risk. So all patients with cirrhosis, now those patients are receiving hepatitis B treatment, no matter what their liver enzymes, no matter what their viral load are. So all patients with cirrhosis are at risk for HCC, as well as patients with a first-degree family member with history of HCC, Asian or Black men older than 40, Asian women older than 50, and patients who are co-infected with hepatitis D. Liver ultrasound with or without AFP in high-risk patients every 6 months should also, which should be the modality for screening for the majority of these patients, unless they're listed for liver transplant, in which we opt for cross-sectional imaging with a CT scan or MRI. Now, the efficacy and limitations of currently available hepatitis B therapies. Well, first of all, efficacy results in potent viral suppression, reverses hepatic fibrosis and cirrhosis, as I mentioned. The limitations, which really are an impetus for perhaps developing direct therapy that may in the future lead to a cure, result in low rate of hepatitis B surface antigen. They decrease but do not eliminate the risk of HCC. And they require a long duration to maintain benefit, which results in high costs, potential drug resistance, and prolonged adverse events. The concern for prolonged adverse events, I'll mention, was more of an issue prior to the development of this more updated formulation of tenofovir, which is the TAF or Vemlidy, essentially with decreased rates of renal impairment, but the same success of viral suppression compared to TDF. The last main point that I'll make about hepatitis B is that reactivation of hepatitis B must be considered in certain populations. And so as an outpatient, in the outpatient setting, if you're managing patients with chemotherapy, immune suppression, certainly those who are co-infected with Hep C or receiving treatment for hepatitis C, have to keep in mind that there's a risk of reactivation of hepatitis B in patients who even have a low DNA level, normal ALT, and even a negative surface antigen. But if they have a core antibody positive, they're at risk. And so the highest risk group are patients on B-cell depleting agents such as rituximab. But there are certainly other high risk groups too. Again, a moderate risk of 1 to 10% of developing reactivation of hepatitis B for patients who are core antibody positive or surface antigen positive, if they're receiving TNF inhibitors and other cytokine inhibitors and integrin inhibitors as well. As I mentioned, rituximab, or the B-cell, as an example of a B-cell depleting agent, often added to CHOP therapy for treating non-Hodgkin's lymphoma, increases the reactivation risk in rituximab-treated patients greater than 10%. So these patients should be treated with antiviral prophylactic therapy for hepatitis B if they are on any of these medications. And again, these guidelines are certainly available through the AASLD as well. So just, I know this is a bit of a whirlwind, intentionally so, but wanted to give a broad overview today of approaching hepatitis A, B, C, and E if you see these patients in the outpatient setting. And so the conclusions for today: hepatitis A and E are transmitted via the fecal-oral routes. Prevention strategies include sanitation and vaccination for hepatitis A at least. Each of these viruses can cause acute liver failure rarely, that may require liver transplantation, and chronic hepatitis E is possible in immune suppressed patients, although rare. All adults should be screened for hepatitis C. 20 to 30% of patients with chronic hepatitis C develop cirrhosis, and oral antiviral therapy for 8 to 12 weeks can cure most people who are infected with hepatitis C. HCVguidelines.org, like I said, is a great resource for managing these patients in the outpatient setting. Transient elastography, or FibroScan, is an effective, non-invasive method of fibrosis staging for both chronic hepatitis B and C. And like I said, certain patient populations with chronic Hep B, even without cirrhosis, should be screened for hepatocellular carcinoma. Before I take questions, I just want to acknowledge our team here at the University of Colorado Liver Transplant Program. So certainly our amazing nurses and coordinators who are an integral part of our team. We wouldn't be able to do our jobs without them. Transplant hepatologists, I've mentioned my colleagues who are all my mentors as well. I'd also like to acknowledge Christy Click, Lindsay Carter, our CME office, and our IT department for their help arranging this webinar, as well as our entire webinar series. This is my contact information as well as our team's contact information. So I've listed my cell phone and email address at the bottom of the screen, as well as our phone number to reach the attending hepatologist who's on call for our center 24/7. And then the phone number and fax number for clinic referrals as well. All this will be saved on the website. Just a couple of quick announcements as well before I go over the questions. We've got a couple other upcoming conferences I just wanted to mention. So our Rocky Mountain Highlights in Gastroenterology and Hepatology Conference is coming up Saturday, August 6th at the Hyatt Regency Denver at the Aurora Conference Center. You can register via the QR code or on the website listed there. It is free registration. And this is the information about this webinar series that we've been doing this year. Earlier this year, I talked about liver transplantation. My colleague, Dr. Wieland, gave a talk in May about non-alcoholic fatty liver disease. And then on October 12th will be the next talk in the series. That's going to be entitled Management of Common Hepatic Decompensations, Nuances and Updates. I really appreciate all of you listening to the talk today. This is another picture of my daughters enjoying the hot Colorado summer. And with that, I will take questions. And again, thank you for your attention. Okay, so again, you can type the questions that you have into the chat box. And I see that there are a couple questions that I'll go over to start with. So the first question says, I have a patient with positive hepatitis E, IgG, the IgM was negative. I ordered a viral load, but how long can this keep enzymes elevated? And is there anything in follow-up that needs to be monitored? Well, it's a great question and obviously a specific scenario and that I'm happy to chat with you more about, Genevieve, offline too, if needed. I guess my questions would be whether the patient has risk factors for like immune suppression that may lead to chronic hepatitis E. Certainly, they should be screened for alternate forms of viral hepatitis, as well as imaging and potentially non-invasive fibrosis testing. But if in the absence of risk factors for chronic hepatitis E, IgG antibody may simply reflect a prior exposure, and there may be an alternate cause for the elevated liver enzymes. And as I'm sure you've done, evaluating for those, including other forms of viral hepatitis, other serologies such as autoimmune markers and other forms of chronic liver disease, testing for those would be appropriate. A few other questions. So who should treat hepatitis B and C? Is it the PCP, physician, NP, PA, GI, or hepatology? Well, great question. And I was trying to allude to that during the talk, but certainly for the vast majority of patients, management of chronic hepatitis B and C can be managed in primary care offices, especially with hepatitis C. I think that 10 years ago, referring to hepatologists to manage hepatitis C would have been appropriate, especially even in the early days of the direct-acting antivirals, when the medications were genotype specific and sometimes hard to obtain. However, at this point, with the pan-genotypic agents and availability of those, the accessibility of those, the efficacy of those, and also just the fact that the guidelines are pretty straightforward and easy to find with that hcvguidelines.org site that I mentioned, a treatment-naive, non-cirrhotic patient really can be monitored by a PCP's office, so any provider. To give you an idea, certainly we see patients in that situation who are referred for chronic hepatitis C, again, without cirrhosis and never been treated before. Usually I see them one time in clinic, get the history, get the recommended labs, and refer from a FibroScan in some cases. Again, that can be done by anybody. And then it's a matter of ordering the medication, which anybody can do, doesn't require a hepatologist. And then we follow their labs and check a viral load 3 months after they're done. And if it's negative, there's no need for that patient even to come back to clinic at any point. So again, that can be managed by anybody. What is your opinion on universal screening of hepatitis B and ultrasound? Oh, excuse me, in the US. I think that like anything with a screening test, there always has to be a question of whether this is would be cost effective. We know what the high risk populations are. And I think that focusing on that is the appropriate first step. Certainly, there are other parts in the world where universal screening is going to be more efficacious at a population level. And when will curative treatments of hepatitis B be approved by the FDA? Well, your guess is as good as mine on that one. I don't know. Hopefully, just like we've cured hepatitis C, there'll be a reduced global burden of hepatitis B and a cure at some point in our careers. And then the last question is, have you seen an increase of HCC? I'm not sure if that's in the setting of a particular viral hepatitis, such as hepatitis B and C. But certainly the burden of liver disease has increased, generally speaking. So cirrhosis from not just viral hepatitis, but actually the viral hepatitis as an indication for transplant has actually decreased, while indications such as alcohol and non-alcohol fatty liver disease have increased. And certainly in those settings, HCC has increased. I think there are areas worldwide where there have been increases in hepatocellular carcinoma due to low rates of screening for hepatitis B. But I wouldn't say that I've seen an increase of HCC just in hepatitis B or C patients necessarily. Okay, well, I think that is all for the questions. I'm just refreshing this to make sure I didn't miss any. Again, I really appreciate all of your time. The next webinar, like I said, I'll just go back a slide here, but it is on Wednesday, October 12th, same time, 12 p.m. Mountain Time. And again, you can find all the information about CME as well as ABIM MOC contact hours on the website. Thanks very much and have a great day.